Hello everyone and welcome to the TPC MCAT video on somatoform disorders and personality disorders. Let's get started. In general, a somatoform disorder is characterized by the manifestation of physical symptoms without a medical cause that can explain those symptoms. Now, there are a number of different disorders that fall under that umbrella, but we'll start with the first one, which I think is the easiest to understand, and that's illness anxiety disorder, or what you'll commonly hear referred to as hypochondriac, or that person's a hypochondriac. And in this type of disorder, the patient is constantly worried about having or acquiring a disease or illness. They will seek tests to check and make sure nothing is wrong. And in this disorder, the actual symptoms that someone experiences are either absent, they don't have any symptoms, or they're very, very mild. So a good example would be somebody who has, mild low back pain, and they come in and say, well, I actually read on WebMD that that's a symptom of prostate cancer, so I want to get a CT scan done to make sure I don't have prostate cancer. But they're like a 35-year-old man. Um, and in this type of disorder, you have to remember that the motivation is unconscious. So the patient is not aware that they are doing this. They're not aware that they have nothing wrong with them. They are actually concerned about it, and that's why they're coming to the physician. Then the next disorder, somatic symptom disorder, is almost like a step up from illness anxiety disorder. And why do I say it's a step up? Well, these patients do actually have physical symptoms that are significant. So they'll have a long history of physical symptoms that cause significant psychological distress. And that's all despite having extensive tests that show they probably don't have any disorder. And symptoms will be things like abdominal pain, chest pain, back pain, ankle pain, pain that is real and gives them significant distress. Now, these patients are excessively focused on the symptoms and will often jump from provider to provider, trying to get more tests done. And once again, their motivation is unconscious. So they don't actually know that they don't have a disorder. They are convinced that they have something wrong with them, and they are actually experiencing symptoms, but there's just no medical cause that we can come up with, despite having extensive tests done. The next disorder is conversion disorder. And conversion disorder is when patients present with a neurological impairment that doesn't add up with any known neurological cause. And the example I have written down here is when a patient comes in with right arm weakness and left leg weakness. That wouldn't really make sense if they were to have a stroke. They would have paralysis on one side of the body. They wouldn't have both sides of the body like that. Another thing that could happen is, a patient comes in and is blind in one eye, but we can't figure out why they would be blind. And this often occurs after a stressful or traumatic event. So a good example would be, a woman loses her son and she comes in and she can't see anymore. So these patients are sometimes not concerned by the deficit, and that term is called label indifference, which is just kind of a nice term you can throw around at some point. And once again, this motivation for this disorder is unconscious. So these patients are not faking this. This is actually happening to the patient, and they're not doing it for any sort of external or internal gain. Now, you've probably heard of this disorder before. It's called Munchausen colloquially, but the actual DSM-5 term is called factitious disorder. And this is when patients intentionally fake symptoms or they secretly self-injure so that they can receive medical attention or sympathy, right? And so some examples of this would be somebody coming in saying they have terrible, terrible abdominal pain so that they can get a CT scan done, or they come in and they've ingested a bunch of insulin so that their blood sugar goes way down. Now, it's important to remember here that the motivation is unconscious. So these patients have a psychiatric disorder. They don't have control over what they're doing. Yes, they are lying, but they're doing that because they have a psychiatric disorder, as opposed to malingering, which we will talk about next. Now, another form of this disorder, which is called Munchausen by proxy, is when a patient with Munchausen disorder or factitious disorder uses another person to gain this medical attention and sympathy. So they'll either convince their child that they have physical symptoms and need to get checked up, or an elderly person that they know, or they'll actually secretly hurt the person. And the way they can do that is by poisoning food. They could purposely infect IV sites to make sure that the person has some sort of bloodstream infection so that they have to get checked up by a doctor. The main thing to remember in this disorder is that the patient craves the sick role. So they crave that attention that you get from being in the hospital and having people check up on you. And the last of these terms for somatic symptom disorders that we have to discuss is malingering. And malingering is not a disorder. Malingering is simply somebody who's faking an illness or faking physical symptoms for external gain. And so the classic presentation of this is somebody who works construction who's saying that they have terrible back pain and can't move, and it's really because they're trying to get workers' compensation or disability benefits. And here, obviously, the motivation is conscious. And so once that secondary gain or that external gain is 1, they will no longer have symptoms. And I've taken this infographic from the TPC MCAT book, and this is just a framework to think through the disorders we've talked about. So as you can see, for conversion disorder, somatic symptom disorder, and illness anxiety disorder, the patient really does think there's something wrong with them. In factitious disorder and malingering, the patient knows there's nothing wrong and they're lying. But remember that for these 4 disorders here, the motivation is unconscious, okay? The person can't control what they're doing. Whereas malingering is not really a disorder because these patients are simply lying. The next topic of conversation for this video is personality disorders. And personality disorders are generally split up into 3 clusters. So cluster A is the weird disorders, cluster B is the wild disorders, and cluster C is the worried disorders. And everybody has their own personality, but a personality disorder is when somebody has a rigid, unhealthy pattern of thinking, functioning, or behaving that gets in the way of them having what we would kind of call a normal life. And so starting off with cluster A, these are the weird disorders. Paranoid personality disorder is characterized by a pervasive distrust of others. So this is somebody who always thinks that other people are watching them, spying on them, lying about them, and they have unjustified suspicions or fears about the loyalty of others. The next type is schizoid personality disorder, and this is somebody who voluntarily detaches from other people. So they actually have no interest in, building social relationships. They prefer being alone, and often they have very, very little interest in a sexual or personal relationship. The next disorder is schizotypal personality disorder, and you'll often see these kind of compared. And so that's a good test question, is to know the difference between these two. So schizotypal is somebody who has odd and eccentric beliefs, and they have magical thinking. So they might kind of believe in dragons or, believe that there are dinosaurs still out there. So these people generally have social anxiety and awkwardness, which leads to social isolation. So it's not so much that they totally want to be alone, it's just that they end up being alone because they feel awkward in social settings. And these people generally have ideas of reference, which is something that you see in schizophrenia. And ideas of reference are basically that things that are going on in the world are always related to you. So, for example, if someone with a schizotypal personality disorder sees some people whispering and looking over at them, they're going to assume that those people are talking about them, whereas somebody without schizotypal personality disorder would probably be like, I wonder what they're whispering about. And there are 5 disorders in cluster B, or the wild disorders, and we'll talk about the first 3 here. So the first one is antisocial personality disorder, and this is what you generally see in people who are serial killers. And the characteristics of antisocial personality disorder is that they have a history of hostility and aggression, and they generally have criminal activity associated with their lives. They have to be at least 18 for them to be diagnosed with this disorder, and they have a disregard for the rights and safety of others. So they really don't care about hurting others, they really are just completely self-motivated. And now conduct disorder is not a personality disorder, but it's what we call pretty much antisocial personality disorder before someone is 18. And so this disorder is generally characterized by harming animals, getting in fights at school, juvenile delinquency. Then there's borderline personality disorder, which is when somebody has a very, very unstable mood and they generally engage in self-harm and self-damaging behaviors. They have unstable personal relationships and a fear of abandonment. And so these people also demonstrate something called splitting, which is when they basically will say, okay, my therapist is the best in the world, and the next day my therapist is the worst in the world. So they only think in extremes. Then the last 2 disorders in cluster B, the wild disorders, the first one is histrionic disorder. And these patients are very, very attention-seeking. They exaggerate their emotions. They're very dramatic, and they want to be the center of attention. And so what they will do is they'll dress very sexually provocatively. They'll dress flamboyantly. They'll also engage in risky sexual behaviors. And the last disorder in cluster B is narcissistic personality disorder, which you probably can guess is somebody who has a very overblown sense of self. They feel superior to others. They exploit others to achieve goals. Everybody is kind of just a rung on the ladder that they can step on to get where they want to go. They want to be very admired and respected, and they are resistant to any criticism. And then the last cluster of personality disorders, cluster C, are the worried disorders. And so the first one is avoidant personality disorder. And this is somebody who avoids contact with others, but they do want to be accepted. They want interpersonal relationships. Right? So very different than schizoid personality disorder. So they want interpersonal relationships. And what holds them back is they have these feelings of inadequacy, low self-esteem. They're very, very afraid of being rejected. Somebody with dependent personality disorder has a disproportionate need for support. So they need help to make any simple decisions, like where am I going to go to lunch? They need somebody to make that decision for them. They have a very, very bad lack of self-confidence, and they're always in relationships. So they're always in, generally a couple's relationship. Let's say their boyfriend breaks up with them. Within the next 2 weeks, they have to get into another relationship, and so they're jumping from relationship to relationship. Obsessive-compulsive personality disorder is very different from OCD, obsessive-compulsive disorder, and these patients are generally preoccupied with lists and details. They're obsessed with being productive and getting work done, and they're perfectionists. So they have very, very rigid routines. They love checklists, right? And what makes this different from OCD is that they have no intrusive thoughts and they don't have compulsions. So these patients actually tend to be very, very successful people because they're very, very regimented, they're very type A, and they get a lot of work done. And that concludes our video on somatic symptom disorders and personality disorders.